All right, y'all. Well, Gottschalk doesn't need a lot of introduction, but today, as we often will do, we're starting out with our immediate faculty. Dr. Gottschalk, as many of y'all know, is our chair of the director of our division and leading our fellowship, as well as vice chair of our department. He's also a phenomenal surgeon who is specialties in many things, including sort of the wrist and hand and some of the more complex things like rheumatoid. So he chose to talk about rheumatoid to give the fellows sort of an exposure to it and hopefully show them some of the cool stuff that we've been doing in the rheumatoid hand and wrist. And elbow too, got shock or just hand and wrist?
Just hand and wrist stuff. I left that elbow.
Okay, sounds good. All right, guys. Well, gotcha. Take it away, and we're recording it, obviously.
Okay. So, as Wag said, I think that the idea behind this talk was that RA, historically speaking, was one of the backbones of upper extremity reconstruction and surgery. And it's a lot of the reasons why a lot of hand surgeons got interested in way back when. Things have obviously changed with the medical management of what we see today. And so, with that said, we still see a lot here in Atlanta. And I think part of it's just the large population that we serve that we still see some of this, but also it's just because of the underserved areas that we treat and typically speaking, maybe access to healthcare. So as you'll see throughout the year, hopefully this talk is meaningful to get you an idea of where we start and what we do. So without further ado, as far as disclosures go, none are technically relevant to this talk. Most of our disclosures, or at least my disclosures, are related to financial remuneration for the fellows themselves. Outside of that, I don't get anything directly. So just kind of general overview of RA. So rheumatoid arthritis, general characteristics, right, is a chronic systemic autoimmune inflammatory process. Typically, we know that it's genetic, so those will pass it down. It's often seen in females more than males. And essentially, it's anywhere between 0.3 to 1.5% of the population. And there's two different distinct features that we see. So one is like synovitis of the joint capsule with subsequent joint destruction of both the cartilage and the ligaments. So keep that in mind. And then another one is what you see with like a tenosynovitis of the tendons. And this is specifically true within the hand and the wrist, where it often will manifest first. And then there's the systemic effects, right? The anemia, the myopathy, the vasculitis, the neuropathy, and or some neck-related complications that you can see in some of the joints there. Some of the pathogenesis of RA, this is kind of like when you see the histology of it, right? It's the white plasma cells, the lysosomes, if you remember all these, and it's often from the oxygen radicals or free radicals that are being released. And this has like acid metabolites, prostaglandins, and collagenases that essentially destroy the joint. And obviously, if you're able to disrupt this pathway of joint destruction, you can preserve people's joints, which is why the DMARDs are so important nowadays. Typically speaking, you'll see that kind of what they call the pannus, Pannus, the synovial proliferation that occurs with that, the swelling, the pain, the ligament disruption, the articular cartilage loss, and then often, as I said, either bone destruction or tendon rupture, depending on where it's located and what it's attacking. For this talk, you'll see that eventually I've um, divided into both a body part, so meaning that as we go from either proximal to distal or distal to proximal, and whether or not it's affecting a joint or the tendons and what we'll see. So as far as like the treatment of RA, right, we are now the last like line of hope, so to speak. So oftentimes you'll see that they're treated first by their internist or rheumatologist. Sometimes they'll see a physiatrist for injections, occupational physical therapist to keep what mobility they have. And then last but not least is typically us as a surgeon, where neither medical management or conservative therapies failed and are looking to have a surgery performed. When we think about our physical exam of these patients, it's not dissimilar to any of the other current pathologies that we treat. Often it's observation, we're looking for deformity, swelling, discoloration, joint motion. So essentially it's the shoulder and forearm rotation, and this has to be somewhat in a reasonable parameters to see where they are. And then for most of the stuff that you do, you'll see Wagner and I, for a lot of our patients, we use goniometers, so they should be in all of our rooms. And we look at elbow, wrist, and digit motion, specifically to get flexion extension, radial and ulnar deviation. And this can be crucial, especially when you're monitoring a patient to decide whether or not they've progressed or not. As far as the digits go, we think of extension and flexion, MP, PIP, and DIP, and then the IP of the thumb. A lot of the time, you'll see things measured as a distance or total arc of motion. So this is like total arc of motion where you're looking at the MCP, PIP, and DIP joint. Or you'll see what we call tip to palm apex, and this is um, located to the palmar crease. And you'll usually use a ruler to see like how many centimeters related are they away from this. So once you've done like your physical examination, you're going through, this is kind of how we break it up into both whether it's a joint issue or a tendon issue. And as I said, this is a chronic inflammatory disease that's autoimmune that targets synovial tissue. And this can be synovial tissue around the joint or synovial tissue around the tendon, as we say here. The joints typically are diarthrodal, and the tendons have to have some sort of tenosynovium around them to see the effects. So as I said, we're going to break it up into joint synovitis and then tenosynovitis. So here, you'll see when we talk about joint synovitis, these are the typical joints that can be affected from the wrist distal, right? So you have your DRUJ, which we'll see the manifestations here shortly. You have your wrist joint, which is composed of both the radial carpal joint and the mid-carpal joints. And then you have your digits, right? So your MP, PIPs, and to a much lesser extent, the DIPs. You just don't see it as often in this in RA. Not to say that it can't happen and there'd be issues there, but these are the joints that are commonly affected. So for the DRUJ, this is often what you see as what we call Kaput-Olney syndrome. So it's an end-stage destruction of the DRUJ. You often will have a dorsal prominence over the ulnar head, pain with forearm rotation, synovitis of the ECU, and this can ultimately lead to tendon rupture. So when you're examining these types of patients that have a prominence over their DRUJ, you look for what we call the piano key sign, and that's essentially where, just like a piano key, when you push the ulnar head down, it pops up like a piano key, right? And that essentially means to say that it's currently dorsally subluxated relative to where it should be. So this aids in differentiating DRUJ synovitis from tenosynovitis. The ulnar head will be prominent dorsally. You'll see that it can be manually reduced. But then as soon as it releases, as I mentioned, you hear this pop up similar to a piano key. And the reason for this is often from the capsuloligamentus issues. So capsuloligamentus destruction of both the volar dorsal components of the DRUJ, which is often the radial ulnar volar and dorsal ligaments. It doesn't necessarily have to be one or the other. Sometimes it's both, but it can be one or the other as well. And this can cause issues. Well, so once you have kaput ulna, where essentially the DRUJ is riding dorsally, you can then get something called Van Jackson lesion or syndrome, which is essentially where you have the DRUJ synovitis, which essentially leads to the rupture of the extensor digitorum quinti in the fifth tendon compartment. And this is like an attritional rupture. And part of the reason why this is an issue is that if their EDQ goes, some patients will not have an EDC to the fourth because that's a common variant not to have. And so it's not as constant. The EDC to the fourth is not as constant as having an EDQ. So some patients, it's hard to know whether or not their fourth compartment is involved or if it's just the fifth tendon compartment. So what are the treatment options that we think about this? Well, resection of the distal ulna is something that we think about. And this was originally considered for RA, but the difference between a DERA and a distal resection has to do with whether or not you lead to styloid. But this is an effective operation for patients with RA, assuming that there is no ulnar translocation of the carpus. And so that is one of the major risks that you run when you do a distal ulnar resection in a patient with rheumatoid arthritis, is that keep in mind, if their radiocarpal joint is implicated in the disease, those ligaments may also have issues, and you'll often see volar and ulnar translocation of the carpus, which essentially you can slowly see the wrist move off of, or I should say the distal part of the wrist, move off of the radial articulation, and that can be a major problem. That's often why we'll consider doing something like an SK procedure in these types of patients if they're already starting to ulnarly translocate. So, as I said, it's not indicated in patients when there's an ulnar translocation of the carpus, which is very common in RA. Instead, you'll consider doing something like this. Nowadays, we don't use pins. You'll see headed or headless screws. But this allows essentially a stable articulation for the radial carpal joint. but also still allows prono and pronation and supination. The only issue that you can sometimes see is proximal stump instability, and typically we'll secure this with either ECU, FCU, or both to some degree. So as I said, this is kind of the SK procedure. It provides stability, limiting further ulnar translocation. Does not correct existing translocation, right? So this isn't going to affect your or correct your radiocarpal joint, but it does eliminate the problem of the subluxated ulnar head. But as I said, it does not correct any of the sagittal deformity at the osteotomy. So the ulnar end may be unstable where people get clicking. Most of these patients are pretty low demand and don't mind it. To be honest. And you know, the Wags is probably the expert of doing these procedures at Emory. But I think he'll tell you overall he's had good success with this. Yet again, it's kind of like everything else. It's the patient indication has to be spot on. So once you get to like the wrist of moving from the DRUJ distal and we get to the radiocarpal joint, this is often where you will see synovitis within the radiocarpal and midcarpal joints. And this can lead to progressive bone destruction and instability of those locations. What we typically see is volar and ulnar subluxation of the carpus, right? And if you catch it early enough, and we did one of these last year in a very young female who's in her 20s, you can do a synovectomy. And Wags is probably going to laugh at this, but this is like the perfect indication for arthroscopy. Arthroscopy is fantastic for this. You don't have to open the joint, and you can actually get better access to most of the joint with arthroscopy, both in the radiocarpal joint and in the midcarpal joint, and do a fairly complete synovectomy of it, which is excellent. And most patients will go on to have symptom-free issues after this, especially if they're already on medical management to help keep the disease at bay. Sometimes this is, I tell everybody, is just to kind of give the medications a head start to do what you need. Similar things can be done in the elbow as well as the shoulder. So if you don't do an early synovectomy, this is essentially what will happen over the course of time. And it's often a progressive disease, as we already know. So if it's caught early, you certainly can prevent something like this from happening. So once you've got destruction or destructive changes, it's too late for a prophylactic synovectomy. So then we have some other things that we can do. And one of the things that's not listed on here is a wrist denervation, which can work great for central erosions and central issues, but it's not great when you have like pancarpal inflammatory disease. So it's one of those things where I didn't list it on here on purpose, mainly because it's more indicated for people that have a very central issue of arthritis or disease pattern in the wrist. So obviously, we first think about motion sparing procedures, and this would be a partial arthrodesis, a shelf arthroplasty, or total wrist implant arthroplasty. And just like the elbow, doing a total wrist in a rheumatologic patient actually has pretty good results relative to post-traumatic deformities. And part of this is just because the patients are so low demand relative to others. Similarly to what we talked about when you do a distal ulnar resection, we try not to do a PRC generally in rheumatologic patients. And this is mainly because it has a higher risk of increasing instability, yet again, because they often have some ligamentous destruction associated, specifically either of the RSC or the short and long radiolunate ligaments. You can do non-motion sparing procedures like a total wrist arthrodesis. And in these patients, they do pretty well. Obviously, in a young, high demand individual, it may not be something that you think about. But for someone that is low demand, you can do this in conjunction with a distal ulnar resection because that way it gets rid of any risk of rupture from the DRJ being unstable. And as I said, if you've already fused the wrist, you don't worry about the ulnar translocation at that point because you're fused. So a couple of motion sparing options. So Wags and I wrote a review article on this. Essentially some partial arthrodeses that will leave the midcarpal joint intact. So the first one is radiolunate, which was originally described by Chimay for RA. And this is essentially just fusing, essentially, as you would think, the lunate to the radius. The more involved one is where you do like the radius, the scapho and lunate, scaphoid and lunate all together. Obviously, a little bit more technically challenging, but a larger surface area for fusion. This was originally more described for SLAC and SNAC. obviously, as I said, it's got a larger surface area, but you also have some loss of wrist mobility with this. So you'll see some people will remove the distal portion of the scaphoid, or part of the triquetrum here to get yourself some better ulnar radial and ulnar deviation, as I mentioned here, and it works okay. When we review this, if I recall, I don't know that there was a huge difference in complications between the two, but something to be aware of. Typically now, as I said, we use screws as opposed to K-wires for this, but these techniques can work well in the correct patient. The shelf arthroplasty is more of like a historical description of things done now, just because of our current fusion techniques. But essentially, what the shelf is was the volar cortex of the radius, because you can see how volar this was, and essentially the carpus was essentially placed volarly on top of this, and this is essentially what it would look like. Um, and how well does it actually work? It works pretty reasonably. But nowadays, right, when you compare it to either current fusion techniques or total wrist replacements, you can see in the correct patients, um, this has actually taken over for non-implant arthroplasty. Obviously, the risks are greater. Specifically, right, their bone quality tends to be worse. So where you see most of the issues or most of the cutout is typically in the distal carpus. There's obviously some newer techniques with locking screws, things of that nature, but it's still not as commonly done as, let's say, total hip, total knee, or other arthroplasties. Some of the more generalized techniques for total wrist fusions, you'll see some patients that have a pretty substantial wrist radiograph. I've actually done one recently that looked almost similar to this, where the patient is so far off with no carpus, and it's pretty shocking. Once you get them back up and over, they do quite well. And so we did their one side, and at some point this year they're coming back to their second. So we'll want one of the fellows to come scrub, but it works quite well for someone that has complete destruction of their joint, where you're not going to do a wrist replacement, you're not going to do a partial arthrodesis, but you're essentially going to do a pan carpal fusion. Um, Obviously, historically, we've used K wires. They used to put Steinman pins down the third metacarpal, and those worked really well. Plates and screws are obviously require a little bit of a better bone stock. It's a little bit more stable fixation to get people moving quicker. The main downside of the plates and screws, besides being more expensive, is slightly larger dissection to some degree. And often the hardware is prominent and can be irritating to either tendons or patients. So it's not uncommon to have to remove them. There's some other intramedullary techniques that have a little bit of a higher complication rate with screws backing out. Typically, you'll see that these can fail distally over the metacarpal, where you'll see that the screws are left in the metacarpal, but they break off at the screw plate interface, essentially. So yet again, just like any other surgery that you do, it's indications of the patient. So not all RA patients are going to present the same way. So regardless of the technique, its meticulous preparation of the joint is critical. Removing all excess cartilage. You want to expose a little bit of the cancellous bone, and you want to maximize surface area. So this is like where curved surfaces are preferred to flat surfaces, and or intussusception of one bone into another. Um, as far as like this is kind of just shows that. So this is like where you could essentially inlay the bone or intussuscept it. And this is like patients that are essentially missing their carpus. So if you have to, having something central inside the bone itself and a slot into the second or third metacarpals. And this is a corticocancellous graft just from the iliac crest. Um, and essentially it's first distally and then you can kind of shoehorn it in. And this has a nice fix. You can fix it with K wires. You can put a plate on top of it, depending on patients. But this is someone that followed up when I was in fellowship that you could see was a pretty significant deformity. Nowadays, most of us would just try and plate this and get this over the top. And there's actually different plates, right? So you'll see some of the more common plates are all to the third metacarpal, but there are plating systems that have ones to the second that go to the base and function that way. So there's a bunch of different options. Um, but you'll see like one of the patients, as I said, that we just did, we essentially fused their metacarpals into their radius because their carpus was completely gone. So moving from the wrist onto the digits, This is often where you'll see a lot of patients come in. More often than not, this is something Wags and I saw a lot in the patients that came in for digital issues, is that even though despite having RA and their wrist may or may not have looked horrible, um, they had no pain at the wrist and all their issues was at the fingers. But we often will start proximally and work our way distal whenever we're talking about reconstructions. And that's because a malalignment at the wrist can really affect what happens to your digits. And you'll see what we talk about here. So just like anything else, if someone comes in with a pretty swollen joint, an early synovectomy can really decrease the rate of progression of any joint destruction. So it may not totally prevent it, but at least it gives them a good shot. It's impossible, especially in MPs and in the PIPs, to get rid of all the synovitis because it will often hide in the collateral recess or beneath the volar plate underneath the metacarpal head. With that said, it's still a worthwhile procedure. I don't know if Wags is scoping MP joints yet, but if he is, I'm happy to send him all these. But I don't know that we have here. So typically for this, we'll still do them open, at least I do. So it's not as good as like doing the wrist or the elbow where you can really scope it and get out all the synovitis. This is just a sample of a patient. Significant synovitis of the MP joints over 6 months. Essentially, this is someone who's probably already on medications, but you can start to see they get this ulnar drift. X-rays are otherwise normal. Normally, we'll have an MRI that shows a significant inflammation. And essentially, it's synovectomies, and I will repeat this, without implants, right? So there's no destruction of the joint yet. And yes, the synovitis could recur, but it's often rarely necessary if they're put on DMARDs. And essentially, this is what it looks like. I typically make a straight transverse incision over the area, and I'll split the extensor tendons down the middle. And then often you do the synovectomy and they get almost complete resolution. And I actually have a few patients like this, some for lupus and some for RA, but they've actually responded exceedingly well. The issue is if you let this go without addressing it early, you end up with patients that have significant deformities to their MP joints. And once you get to the point where someone's got complete subluxation and/or arthritis of the joints, you're essentially now looking at having to do implant arthroplasties. And I didn't go over this in detail, but we can kind of talk about the various reasons as to why someone will get ulnar drift of their fingers, right? So one or two happen at the wrist. So the wrist oftentimes will radially deviate, ulnarly translocate, and go volar. That will typically kind of give you a slight deformity that will pull the tendons into an ulnar drift. That's just one of the various reasons. The other reason is typically based off of the line of pull of the flexor tendons, and that can cause issues as well. But essentially, once they start to go, it's also because the sagittal band is weaker on the radial side than it is on the ulnar side, and so you get these kind of slow but attritional issues. And then, of course, your volar plate and your collateral ligaments will also go with the synovitis at these. And so it doesn't take much for that to happen. Um, you'll see that in order to do a proper implant arthroplasty, you have to get resection or resect the radial head just to be able to get it back out to a normal length. And it's oftentimes a resection alone of the metacarpal head may not be enough to overcome the soft tissue contractures. And typically, when we talk about soft tissue contractures, we're specifically talking about the intrinsics about the hand. And so these are the various implants that have been used before. They're often silicone implants for spacers, and a pseudocapsule will often form around them. It's the least important part of the operation as far as the actual, like, hey, what size are we putting into that? It's often related to how much resection did you make of the metacarpal head? Did you release the intrinsics? Did you do cross intrinsic transfers? Did you release the volar plate? Um, as I've done more and more of these over time, I've learned something every time that I do one. And I will tell you, probably the biggest change was watching Marco Rizzo and Steve Moran come in and kind of showed their technique of how they shore up some of the ligamentous issues around the MP joint, specifically doing what they call the Beckenbaugh stitch, which is kind of like an inside out, outside in stitch of the radial side, typically, that essentially tightens up that side and almost brings in, and we can probably do this in one of our labs. just so you guys get to see it. And we've historically brought one of them down to do this with us, which would be a great opportunity again. And essentially, you're going to correct all the soft tissue contractures by releasing the intrinsics. You'll typically um, release the ulnar-sided intrinsic and move it to the radial-sided lateral band. And we can show that as well. They look like wimpy structures, but they're often pretty tight when you release them. And then I release the volar plate in a lot of these patients to the point where you can actually look at the tendons below because that helps the contracture release as well. Typically speaking, if you guys can see me, you're taking someone who has essentially got a contracture with their fingers at 90 almost into their palm, and you're shifting their arc of motion to being all the way straight and then being able to get down to about 90. It's not going to be perfect range of motion, but it's often quite good. And these patients can have a pretty remarkable recuperation as far as how they do. Just like anything else, even though the surgery is important with how we do them, the post-operative recovery is just as important. So I still use a dynamic extension splint, which looks similar to this. It's got a little outrigger that has rubber bands that centralizes the digits and a passing them. And this, as I said, can get you a pretty remarkable recuperation for people that had no function of their hand. With that said, just like everything else, complications can happen. You can have broken implants. I revised a patient recently where they had broken through all of their implants, and all I did was literally essentially take out the implants, put in new ones, and it kind of popped them back into a more normal alignment, and they hadn't had it for almost 10 to 15 years. It was pretty remarkable. Sometimes you can see significant synovitis around the prior implants, which can cause them to break. And you used to see this more in the patients that had essentially a total wrist replacement with a silicone replacement. Oftentimes, you'll see patients had a period of time where they were normal. They may now notice a deformity. Typically, pain is not one of the issues that RA patients have. More often than not, it's just a lack of function. Uh, this is one of those things that sometimes you have such severe bone erosion that you can't actually put in implants. There are different types of replacements that are non-implant. This is the one that we think about what we call the tupper, which is essentially you take the volar plate, you detach it from the metacarpal, excise the metacarpal head, and then you take the volar part, which you leave attached. You take that part here, you leave this part attached, pardon me. You take the volar part from the metacarpal and you move it to the dorsal here. That's called a tupper arthroplasty. And then the other options is where you use portion of the extensor tendon to interpose, and then you advance the tendon up over that area. This is the Vano one. I've done the one on the left. I've never done the one on the right. But the idea is that you just advance the extensor tendon into the defect. These are for people that have pretty advanced, pardon me. So this is for people that have pretty advanced metacarpal issues. Theoretically speaking, you could do it in post-traumatic or traumatic deformities that we see at Grady, but never had the opportunity to do that in that setting. Typically for RA, where you're either revising an implant and it's gone or something of this nature. So more often than not, most of the arthroplasties you'll see on our services will either be at the wrist or at the at the MP joint, which is probably the most common area you'll see us do small joint arthroplasties. With that said, you will see deformities at the PIP joint exceedingly common. RA or autoimmune diseases are one of the few times when you look at fingers next to each other, you will see a difference or can see both a swan neck deformity in one finger and a boutonniere deformity in the one adjacent to it. So essentially, you can have a variety of different ones of issues, and it can be different on each finger. It can also affect the thumb. And so swan neck deformities, this is where you have PIP hyperextension and DIP flexion. In some patients that like show up to you without RA, it's sometimes hard to figure out, is this actually at the DIP joint where they've got a mallet, or is this at the PIP joint? Now, theoretically speaking, you'll notice that this can actually occur at any of these joints being recalled. So the MP joint can be relatively to an intrinsic contracture, right? So the MP joint, that means that you'll have hyperflexion at the MP and hyperextension at the PIP. That's what happens when you can see an intrinsic contracture related to RA. If it's at the PIP joint, it can be related to a couple of different issues. One, it can be related to both the synovitis, which is the attenuation of the volar plate, and that's your static restraint to hyperextension, as you know, or it can be tenosynovitis, which is attenuation of the FDS, which is the dynamic restraint to hyperextension. So it can be either one of those. And then you can also have it at the DIP joint where you can get an attenuation essentially of the terminal slip. So um, the type of swan neck matters. And part of this reason is because it matters whether or not your PIP joint, one, if that's where it's occurring, but two, whether or not it's a tight joint or a flexible joint. So in patients with a type 1 flexible PIP joint, their joint locks in hyperextension and the patient has to initiate flexion using the other hand. So essentially, once you overpass that, they can then flex. That's important because if you can give them a moment where they're not hyperextended or put them in a splint, they can actually function well and get their stuff. Type 2 is where they have a flexible PIP, but they have some intrinsic tightness. So essentially, they're stuck straight, and they're trying to overcome their tightness of their intrinsic. And you can once you get them past a certain level, you can see that they actually have some improved motion with the Bennell test. And then those that have a stiff PIP joint, which you can essentially find out by X-ray, where the joint is preserved or the joint is arthritic. So depending on the types, depends on what you do. So for types 1 and 2, where the joint is flexible, you can put in a double ring or oval 8 splint. And these patients can do pretty well, and it eliminates the PIP hyperextension, but it doesn't interfere with flexion, so it means that people can still use it. I have several patients that they use this because these are all of $1 or $2, and that's all they want. Now, when I was up in New York, we had patients that had pretty elaborate stuff, and this is essentially someone who had gold ring splints made for them. But essentially, you could do all this. I just had someone come back in specifically just for their splint, and it's often made out of silver. There's a specific OT person that will measure and they'll send it off, and then they send it off to a special company and they make them for them. It's pretty neat. Um, for type 1 and 2 surgical management, yet again, where you have flexible PIP, essentially, if you can release the tight intrinsics and or prevent the hyperextension, then this works. So there's different ways to do this. You can do an FDS tenodesis. You can also do a lateral band tenodesis. The biggest issue for a lateral band tenodesis is that it's a pretty wimpy structure. So you've got to do it in someone that's low demand. And this is typically, this was one of the cooler surgeries I did when I was in fellowship. This is essentially where you take your lateral band, you cut it proximally, and you bring it underneath Cleland's ligaments, essentially, and you pull it through, and then you tack it back up to essentially where it was. And now it's tethered volarly so that it cannot extend. More often than not, whenever we do these, we typically tend to pin the joint in 20, 30 degrees of flexion for a period of 4 to 6 weeks. But they can actually do exceedingly well. So like pre-op, where they couldn't curl, now post-op, it's a pretty remarkable ability to get them back into some normal function and in a normal looking hand. Type 3 and 4, where people are stiff, this is the one where either you can do like, a capsulectomy and or a tenodesis, or if they're arthritic, we often fuse them. And fusions for RA patients do exceedingly well at the PIP joint. Oftentimes, because we'll couple it with an MP joint arthroplasty, because they often have multiple issues. It's a lot more rare to do a silicone PIP joint arthroplasty. Part of the reason is that the vast majority of the time, their collateral ligaments of their PIP joint are not good. And often you can't do that in combination with an MP joint either. So just something to keep in mind. Now, when you look at the boutonniere deformity, it's the exact almost opposite. So instead of the PIP joint being in hyperflexion, or pardon me, hyperextension, you've now got an inflection. And this is only at the PIP joint. And this is typically because of the synovitis at the PIP joint, which will attenuate the central slip and potentially the distal aspect of the ligament that goes just distal to the central slip. And this, you often have to figure out whether or not it's a flexion contracture where the tendon mechanism has not been injured. And often you have to look at the DIP joint, not the PIP. So this is something that I try and tell everybody, all of our trainees, is that if you think it's a boutonniere because their PIP is held in flexion, you really have to look at the DIP joint. And if the DIP joint is unable to be moved and is an extension, then you know it's a boutonniere, right? So if you can't move the DIP or it's hyperextended, that's a boutonniere. If they have full motion of the DIP, it's not quite gotten onto a boutonniere yet, and this is something that we call a pseudo boutonniere. And a pseudo boutonniere is specifically just a PIP joint contracture, and it's often related to a simple hyperextension injury from trauma, where the volar plate now contracts down. These can be exceedingly difficult to treat because even when you do releases on these patients, they tend to have issues. Wags and I have tried almost anything and everything, as I'm sure many of the other folks on the call have. Um, but we've tried digit widgets, we've tried capsulectomies, we've tried uh, essentially check rein ligament releases. Oftentimes, it's so painful, people have a hard time getting the finger back straight. I feel like recently I did one with the digit widget and the person got back, but these are difficult to treat for sure, just like boutonnieres are. Um, so stages of boutonnieres, there's often a variety of different stages as well. So yet again, stage one, slight extension lag at the PIP joint. Um, and these people often will have some issues at the DIP. So this gets very controversial where they used to call what they call a Fowler procedure, which is where essentially you cut the extensor just distal to the triangular ligament over the middle phalanx. And this causes a PIP issue, but often will allow you to flex at the DIP. Stage two is where you have a flexion deformity to 40 degrees. As long as the joint is flexible, this can be corrected. And then stage three is where you have like a fixed deformity, and that's essentially a fusion is your only choice. So when we look at these, this is essentially someone who is good passive PIP extension. The lateral bands are displaced volar to the axis of the PIP, but no central tendons because they're totally eroded. This is someone where you can essentially suture your lateral bands back up over, right? So lateral bands are mobilized and they're sutured together at the PIP. PIP joint remains pinned. These people will often have some stiffness, right? The joint's never going to be quote unquote normal again. Um, these can be very difficult to treat. And I typically just tell patients, like, look, it's never going to be a normal finger again, no matter what we do. Oftentimes, they're so contracted down. The first step is just getting them into therapy and do static progressive splinting or something of that nature. Just like the PIP joint, you can also have issues at the thumb, which is what I was talking about. And the rheumatoid thumb, and you'll see Nailbuff has a couple of classification systems named after them, but there was originally three for the thumb. And one is kind of like a boutonniere, where essentially the MP joint is actually your PIP joint. And here you can essentially see that you've got a flexion deformity at the MP joint, and you've got a hyperextension deformity at the IP joint. This is often related to synovitis at the MP joint, which stretches the dorsal capsule. And this is where the EPB and EPL will displace. And specifically, the EPL will displace ulnarly and force transmitted. The force is transmitted to the IP joint. In the other ones, like type 2 is similar to type number 1, but this is where the CMC joint's involved. And then type 3 is where you have a swan neck deformity, which is almost like a Z deformity here, where essentially you get MP hyperextension and IP flexion. This is the CM joint's involved in type 2. It can be involved here. So you can actually correct the CMC joint and potentially the MP joint, but it all depends on how supple it is and whether or not it will come back down and whether or not you do a capsulodesis or a fusion. Typically speaking, it's just like anything with like CMC arthritis. For us, the threshold is, at least for me, 0 to 30 degrees, you do nothing, you just correct the CMC joint. 30 to 60, you do a capsulodesis. Greater than 60, you fuse. And that's specifically for the MP joint of the thumb when it relates to a CMC issue. And that study was actually from Marco Rizzo out of Mayo that really looked at those and that was for CMC arthritis. So not specifically for RA, but more for OA. These are some 3 additional types. So one is a gamekeeper's type thumb, where you can see this person can't hold a pen properly. Treatment is a fusion of the MP joint, and it corrects the adduction contracture of the first metacarpal pretty quickly. And then the other two are where essentially the MP is hyperextended, but the IP is flexed. This is similar to number three, but here the CMC joint is not involved. And this is normally from a volar plate issue. And essentially you just do a capsulodesis or fusion of the MP joint, it works well. Um, and then type 6 is essentially significant bone erosion. So those are all the joint issues. And I'll answer questions at the very end. Now we're going to move on to all the synovitis that you can get. So this is different from affecting your joints. Sometimes the joints can cause attritional ruptures. This is where the disease has directly attacked the flexors or extensors of the digits or of the wrist. So tenosynovitis, typically you see it affect the digits, the flexor tendon sheaths, and the wrist. You can see it in the extensor retinaculum or under the transverse carpal ligament for the flexor tendons. Tendons surrounded by either one tenosynovium or peritoneum. Tendons and sheaths have tenosynovium. Sheaths are on the concave surfaces of joints to prevent tendons from bowstring, right? So when you look here, um, if you think about where the tendon sheaths of the hands and the wrist are, you'll essentially see them on the back portion of the wrist that are concave or on the volar surface as well. So wrist, it's the dorsum under the extensor retinaculum, volar, it's under the transverse carpal ligament, and then the digits, it's the volar aspects of the thumbs and fingers. There's no tendon sheaths on the dorsum of the digits, which is why you don't see extensor tenosynovitis at those sites, meaning you can't get it on the dorsum of the fingers. It doesn't exist, right? Because there's no sheath there. So causes, as I mentioned, causes of tendon ruptures can be anything from tenosynovitis, where it's a direct invasion of the tendon, or attrition, where it's abrasion of the tendons against bone or erosions because of joint malalignment or issues. So tenosynovitis is kind of what we were talking about. So flexor tendon fingers may trigger. And this is, as I said, I think I was discussing that I did a wrist arthroscopy on a patient recently. Her first manifestation in her 20s for her RA was essentially a trigger finger. But it wasn't, her finger was swollen. It wasn't normal. We got an MRI. She had all the synovitis. And perfect example, young female with a synovitis in the finger. It's essentially RA until proven otherwise. Obviously, there's also other issues that it could be, such as like infection, but it should really tip your hat off to me like, hey, I think this is something autoimmune potentially. And sure enough, when we got all of her labs, it came back as RA. And then, so we did essentially a flexor tenosynovectomy. We tried, we always try and keep the pulleys intact and do the synovectomy, but you can excise the A1 or incise it. Our study showed that incision actually did better than excision. A little slightly different in someone that's got significant RA, but obviously you do a significant tenosynovectomy and you try and keep all the other pulleys and everything else intact, but it's a pretty remarkable difference once you do a large one, and these patients do really well. Yet again, assuming once you've done the tenosynovectomy, you put them onto some sort of medication management, or at least if you've prior to anything surgical, you'll have them potentially try the medical management plus minus injections, and if that fails, then you'll go on a surgery. Typically, patients will come in and they've got like these large lumps or bumps, either volarly, dorsally, over different areas. They can have carpal tunnel syndrome associated with it. One thing I will caution people is that when you see these large lumps, sometimes you can have patients that come in and you can be fooled that it's RA. I've had a patient that had a some sort of random weird sarcoma. It's like a myxofibro something sarcoma that looked like tenosynovitis. I've had infectious that I thought was RA, but it was actually TB, some sort of mycobacterium. So like you can have all sorts of random weird stuff when you start taking these things out. But you can do a pretty extensive tenosynovectomy where they can actually get pretty darn good range of motion back. You'll see, we often will call it like a dumbbell sign where you can see on either side of the retinaculum or either side of the wrist. But you can get associated carpal tunnel with this, so you got to be careful. Um, this is one of those like test questions that everyone always likes to ask about Mannerfeld lesions. I've seen it twice in RA patients, but essentially patients will get STT arthritis, and the FPL will come over the osteophytes or around the area of the joint and will rupture. And the FPL is the most common flexor tendon to rupture, followed by the FDP of the index. And essentially the tendon is just a braid over the area of the bone. You can see it on CAT scan, X-rays. once you get an attritional rupture, you can't just repair it. You often have to do some sort of reconstruction, either whether it be an interposition graft or a transfer like of the FDS tendon to the ring or something like that over. And this is referred to as a Manifelt. One of the treatment options besides reconstruction is sometimes you have to address the arthritis here if it's gnarly, either with a fusion or with a trapeziectomy or with an osteophyte takedown. Yet again, interestingly enough, these patients don't have significant pain over the area as their number one issue. Occasionally, you can get it associated with the tendon from the attritional rupture that it starts to bother them, but it's not normally their number one problem. Um, as far as like tendonitis of the wrist extensor, this is kind of like the dumbbell area. As I said, you'll see this like dumbbell configuration from where there's issues. This is easier to decide what it is over, like, let's say, a cyst, because you'll ask them to extend their fingers and you'll see the synovium move back and forth. And that's exactly what I'm saying here is you can see them move their fingers and then it will go with it. And then oftentimes you can see this dumbbell kind of shape. And most normally you'll get an MRI to see the extensiveness of this. And it can be pretty substantial. One thing I will tell you is that when you go in there, it is not uncommon to find tendons that are either on the verge of rupture or those that have already ruptured. So you always have to have a contingency plan of what you're going to do. And this is typically what we think about. So when the synovitis is persistent, despite having medical management for 3 to 4 months, this is often where you think like, okay, you're going to essentially go in there and do a synovectomy to get enough of medical control over their issues. So obviously, advantage of the tenosynovial graft is that the recurrence are very rare if it come back, yet it can. This is obviously a very low. One of the issues, obviously, is if you have to go there multiple times, is the retinaculum will go on either side. Typically, you can suture it back if done well. Sometimes the retinaculum, though, can be very atretic, which can be issues. And yet again, this is what I was just saying. Make sure you close the retinaculum. And this is essentially important to try and reduce bowstringing on the extensor side, which, although rare, can happen. So this can actually be so extensor tendon ruptures can be quite common. It's a more difficult surgical problem than the tenosynoviectomies prior, so that's why we essentially recommend it. And so this is kind of what we'll go over. So if it's just a single tendon, we try and transfer to a distal ruptured tendon end into an adjacent one. That works great for when it's one finger. When you have two fingers gone, typically speaking, it gets a little bit difficult. So that's when we'll start to think about tendon transfers, and I'll go into that in a little bit about which one. But that's where you may transfer the EIP tendon over to one. And essentially, the EIP can actually function for two fingers. So if you have three, one you can put into an adjacent, and then the other two you essentially have to do a transfer. But this can cause issues, as I said, because a single tendon from one, you'll have a droop. So if you try and transfer two tendons into one healthy one, your fingers will droop. It will essentially cause issues. Having a bridge gap, so doing some sort of bridge grafting between the ruptured ends, you've got two suture sites, so you got larger chance of adhesions. This is often, some issues with excursion, but can cause problematic, but it can be done. And then joint fusion is an option, but typically you mostly consider it for like the thumb. You don't really consider it for any of the other fingers. We don't often think about repairing anything that's been atretic or attenuated dramatically just because it's not feasible. And this is often because the excursion is so large that you can't get it overcome. So this is just like what it can look like. You can have a significant amount of issues. So here I'm just going to show you you can hook the ring and little. So essentially, tenosynoviectomies and distal ends of ruptured tendons, so ring and little attached to intact tendons, index and middle, right? So essentially we did one to each one, not two into one. But yet again, technical tip, the distal ends must be long enough to permit this, right? So that's part of the issue is that it has to be long enough. But if done well, it can work. The other stuff, so here where you've got multiple tendon transfers, so rupture of the extensor ring and little fingers, if the distal ends are too short, then this is often where you'll think about either tendon transfers like the EIP to both tendons. And as I said, it has sufficient force to motor one finger, two fingers, but not enough for three. And so that's just something to keep in mind as to how many you have and where you're going to transfer them. Um, so if you have ruptures of all the digit extensors except for the EPL and EIP, what tendon transfers long enough? Well, the FDS to the middle ring. You can come around, you can come through the interosseous membrane. Um, and then why does it matter? So typically speaking, we used to do it on the radial side to reduce any ulnar deviation. But you got to make sure that you have enough to reach. And the excursion is pretty good, but this is a little bit of a non-synergistic transfer. So you just got to be a little bit aware of that. And then, um, ruptures can be prevented with tenosynovectomies. People always ask me, just like carpal tunnel, how long, if I wait too long, how long is too long before, I'll have atrophy or wasting on my muscles? And the short answer, you just don't know. And so this can all happen. And typically we'll recommend that people undergo tenosynovectomies if they can be on medical management. But overall, a lot of this stuff can be prevented now with DMARDs. So it's always a little upsetting when you see someone come in with either tenosynovectomies or other issues because if they would have caught it sooner, this was all preventable. So that's all I have for you guys tonight as far as like RA. I'm assuming someone will have some questions or discussion points of things to go over, but hopefully that was a little bit more didactic than usual because sometimes we'll just go over cases, but pretty kind of all the routine things that we think about with RA. And I think you guys are going to see some of this. We probably have some patients coming up at some point. I know I have at least a wrist fusion coming up in essentially an RA patient that would be a good case. Right.
That was
Yeah,
great.
Gottschalk, that's great. You want to talk about when you're doing realignment procedures on MCPs? How are you making a decision to do a arthroplasty versus just doing realignments?
Yeah. So typically speaking, they have to have no actual arthritis yet. So like oftentimes we'll get, well, she'll definitely get X-rays. Occasionally, if they're super young, you'll have an MRI. But more often than not, if they have no arthritis, meaning there's no actual joint destruction, and it's just either subluxated or slightly off, that can often be overcome. Not always, so it depends on the degree of subluxation. But if it's a mild ulnar drift and there's no evidence of arthritis, those people get realignment. And there are patients where you'd be shocked where it's like, all four fingers can be affected, but I only replaced the index and middle, and I just realigned the ring and small. And that's just because of the amount or degree of arthritis that they had. So if they didn't have arthritis in the two ulnar joints, I essentially did realignment for them at the same time I replaced their index and middle. So it's
Nice.
all based off of the degree of subluxation and the amount of arthritis.
And are you yeah, no, I agree. That's similar for me. All right, so one question I don't do that you told me at least that you were gonna do. I don't know if you've done it yet. Are you doing the isn't it ECU transfer that Rizzo showed you?
Oh yeah, so that was actually so I've done N of one. So take it as what you take it for. It's called I think it's called a clay transfer, is what it's called. I didn't put it on here, but I probably should because we have the pictures. We essentially took an ECRL. So we take the ECRL, which is a radial deviator, right? And we transfer the ECRL into the ECU. And so essentially that actually takes a radial deviator into an ulnar deviator. So essentially it realigns the wrist to centralize it. And that I did in someone who had horrible MP joints, um, but her wrist was essentially somewhat normal with the exception of some mild deviation. Wasn't a lot of volar. So yet again, things that we think about the wrist, you think about volar subluxation, radial deviation, and ulnar translocation. Okay, those are the three movements of the wrist. By taking away the radial deviation and pulling on the ulnar side, you almost kind of shift it back up into neutral alignment, and that actually allows your fingers to be a little more straight. So Wags, the one lady I did it in, who essentially everyone told her that it could not, her hand could not be reconstructed, was like blown away because she almost has full range. Besides that, we saved her wrist, her MP joints that we replaced all of them. she has almost full range of motion. It's actually probably one of the best reconstructions I've ever done. It's also the most recent one. So I'd argue, as I said, every time I do one of these, I learn more and more and more. That was
And
a
so,
Rizzo.
but you're
Uh,
not doing it in patients who have the bad volar and ulnar translocation. You're doing it in subtle because are you,
yeah, so I wouldn't do it in someone
or are
whose
you going to
arthritis
start
is.
pushing the envelope and do it in that person who has the bad volar and ulnar translocation?
No, I honestly I haven't. We haven't had one in a while. I haven't had one. As I said, I've done one, and that was in the last 6 to 9 months. I just haven't had another one yet. I'm sure we will at some point,
I
but
know, but let's say you do, because as you know, but everybody on the call should, our approach has been slash at least your and my approach has been doing total risks in these patients or fusions versus total risk arthroplasty in the patients to kind of relocate them before you move on to the MP procedures. The ones that had the bad risks, the ulnar
yeah.
and the question, are you thinking that you can do that transfer instead of doing like a total risk or a wrist fusion?
I don't know. I sent the lady that I just did one in. I sent to Marco just to get his opinion, and he thought it was he was like, "This is the perfect candidate for it." I think once you get enough arthritis or malalignment, I'm not sure how good it is, to be honest. I think it's
Yeah.
like one of those things like it has to be early enough or not. Like it's kind of one of those people that you kind of get the X-ray, and you're like, it's malaligned just enough that you're like, what to do with it. But I'll be honest, I didn't even know that this transfer existed until Marco came to talk
Yeah.
to us about it. So it wasn't in my armamentarium to be like, oh, we should be doing this on every patient that comes through. I think it's just like everything else. I think it depends on the disease severity. Once they're like so ulnerly translocated or so badly arthritic, I still think the right option could be the wrist replacement or a fusion. Now, I would argue if you do a wrist replacement and they have a known kind of static kind of issue or deformity, it is something that you could probably do at the time of the wrist replacement.
Yeah. That's a good point. Yeah, because the wrist replacements that we've done or these have done these, they still have some deviations. That's a good point.
For sure, for sure, for sure.
Um, it's interesting because like those of you, so Cam, Anthony, and Tim, like one of the hardest conversations I've had with a patient is talking them in to doing a wrist replacement when they're coming to me for MCP pathology. I mean, they're coming to say, hey, my fingers don't work. And hey, by the way, before you reconstruct your MCP, I think we should replace your wrist or fuse your wrist. And they're like, wait, I don't have wrist pain. Why were you touching my wrist? I just want you to fix my fingers. It's a very hard conversation. But do you know why we have that conversation, or do you know the logic behind that?
Like Dr. Gottschalk mentioned, you want to reconstruct from proximal to distal because the deformity proximally will alter the mechanics of your distal structures. So when your radius is going radially, it makes your carpus translate ulnarly,
Yeah.
alters the MCP digits to volarly subluxate, uh, is my
Yeah.
understanding.
But why not just like try the MCPs first, and then if that doesn't work, then you can go do the wrist.
I think you still have a deforming force that's going to be impacting the distal structures. So it'd fail.
Oh, I know, but then I'm gonna do the MCP first, and then if that doesn't work, then I'll go to the wrist afterwards. Why wouldn't you just do it that way?
I guess I'm not sure.
The answer is like if you do the MCPs first and it fails, that's a then you go to the rest, then you have to still redo the MCPs, and then you have a hard problem in the MCPs because you've already hopefully done crest intrinsic transfers, you've already done the Beckenbach stitches, you've already done the realignments, you've already done the arthroplasties, and yet they failed because you didn't correct the wrist. And so that's the idea is you do the wrist first because you don't want the MCPs to fail because if the MCPs fail, I mean, there's not good revision for a failed, homologation MCV. That's the idea. Is you want to try to give them the best chance from the beginning, so you set them up for success. I've seen, I'm sure Gottschalk or Nina or anybody else on this have probably seen some referrals from people who've not had that done, and they get referred to you for the MCPs, but they've already had the MCP arthroplasties done, and you're just like, what do you do for that patient? And there's not, at least in my mind, there's not accurate answers unless if they haven't had cross intrinsics, then you can give it a shot. I guess I would probably give it a shot, but otherwise, it's
It's
a
a
hard
much
call.
harder problem. I mean, Wags, I've revised a few recently, but as I said, I mean, I think the back and boss just kind of changed everything for me, even in the revision setting. where I've been able to get some decent stuff. But I used to also split. So I've changed how as I said, I've changed a few things of how I did this. So things, if you ask me what I've learned, I used to split the sagittal band on the ulnar side and try and like get the wrist, get it all the way back over, which occasionally I will still do, depending on how much of a degree of malalignment there is. But I've also gone now to like splitting the extensor tendon down the middle. So like if the subluxation is not
On
horrible,
MTBs, why are you doing that? That makes no sense. Why not do this out of band? Because you want to release this out of band anyways. You have to release this out of band to realign the extensor.
so I do on like the very, very severe ones, I will because they're so far over, I don't have to actually split it. But
Yeah.
in someone that's actually straight or pretty straight that has arthritis and is not fully coming over, I often will try
But then
not
you're
to
not doing
mess.
cross intrinsic transfers and all that stuff.
Yeah, so I do on the real on those folks I will just to get rid of the intrinsic release. But I guess so let me be very clear. On the people that have very mild subluxation with horrible arthritis, I'll go through the extensor tendon. On people that are so far dislocated over that essentially their extensor tendon is not even over the joint, you can essentially get access to the joint without ever going anything. Those you have to release the ulnar sagittal band to get the it back over, and you're essentially reefing whatever tissue you can on the radial side. So those I don't split the extensor, if that makes sense. So on the very severe ones. But I essentially will do cross intrinsics on everyone. But what I found, as I was saying, Wags, is that I think I can't remember if it was Steve or Marco that showed me, but the Beckenbach stitch really is a very powerful tool as
Yeah.
far as like the stitch that goes in. And I use I use like a number two
Yeah.
suture to because it's a pretty large one. And sometimes I'll go through the bone, through the ligament, down, out through the bone, through stuff. And then essentially you'll put the implant in and you tie it afterwards. It's a pretty remarkable thing. And then once you keep them extended, it often will kind of heal in, or I don't know if it just scars in, but it seems to really change how well my patients do afterwards between that and changing some of my other stuff that they showed me.
Yeah. I like you give them credit. I showed you that stitch, but of course you don't listen to your partner.
Yeah, they should do. But then I just had them show it to me when they
They
came
showed
out.
me for sure, but I showed you before they came down. You're ridiculous. But yeah, that is a common. I mean, that is. I think Nina is Zelensky on. I think either of
Nikki
them can
is. I
attest.
don't see Nina.
Any of these PIP or MCP arthroplasty we do up there, that's like their go-to for these for collateral reinforcements.
Yeah, absolutely.
Um, yeah, so I have one more question for you, Chuck. I've never done this, but have you had success with doing synovectomies and getting people feeling better in the wrist or in not with like for say, extensor synovectomies, but actually wrist synovectomies, getting
Oh yeah.
people feel better? I've never actually done that, but I don't. I guess I don't see that many with early arthritis.
I mean, it all depends. Look, the most recent one I've done was a patient, as I said, she's now 31. When I originally met her, she was either in her late teens or early 20s. And I think she just turned 30 or 29, somewhere around there. Essentially, she came in with wrist pain now on DMARDs, and she has some erosions in her wrist, but she's so young. I said, we're going to do a synovectomy of her wrist and give it a try. And she's done phenomenal.
Yeah. Okay.
And
How do
that
you
was done
decide
within
it's from the
that was done within the
synovium and
last
not
year.
from like the early arthritis or not from, probably they have SL tear, probably they have a bunch of other stuff. How do you decide it's from the synovectomy and not doing like an arthritis procedure like a denervation?
We didn't do a denervation on her. I think all we did was a synovectomy.
That's what I'm saying. So how do you decide synovectomy versus how do you decide versus like an arthritis procedure? Because I feel like that would be a hard thing to distinguish
Well, so
between.
it's kind of one of those things like the only time I actually ever feel like I see RA patients in pain is when they have like a significant effusion in the joint with synovitis. I think outside of that, when they've got active synovitis, is like the one few times that they complain of pain. Because as you know, some of these people come in with the worst deformities you've ever seen and have no pain. And you're always shocked. You're like, how is that possible? Like they have like full range of motion on their wrist looks horrible, and they're not moving it. So, I mean, the short answer is I don't know, but just like you, I've maybe done like two. So it's not like it's like I've seen so many, but that was the most recent one we did, and she did great. I think it's just like anything else, it's like patient selection.
Yeah.
You got to catch it early enough.
Yeah. That's fine. Oh, great stuff. Tim, Cam, Anthony, you guys have any questions?
I just had a question on, you were talking about maybe seeing it as the first manifestation of their RA. coming from Michigan, it was hard to see a rheumatologist. Do you start any of that workup, or you just try to get them into rheumatology as soon as possible? If you're the first one seeing them presenting for RA.
Sorry, say that again.
Cam's saying that if you're the first one seeing this patient, they have not been diagnosed with RA, but you see signs that they have RA, what do you do? And he's saying when he came from Michigan, there's not a lot of rheumatologists available, so it's hard to get him into rheumatology.
Oh yeah. Are you still? We're still recording.
You do me? Yeah, I can stop recording.